questions. This is also a Laura Mann lecture, so I have a few words to say about that just to get started. So the OSHA Center for Integrative Health at UVM's Laura Mann Integrative Healthcare Lecture Series has brought experts in the field together to educate and support our community for nearly 15 years now. Free, open to the public, and often presented during grand rounds. As in this case, these events honor the legacy of skilled, beloved, and visionary midwife Laura Mann, who built the first center in our region devoted to integrative healthcare, which merged with UVM Integrative Healthcare in 2015. These lectures are designed to engage multiple populations and increase our understanding of how an equitable whole health approach can optimize the health of individuals, communities, and our planet. And we will be monitoring the online chat. So please feel free to put comments and we'll address questions at the end. This presentation will also be recorded. It will be made available publicly on the OSHA Center for Integrative Health website, which we'll share details of at the end. So for this Laura Mann lecture, I'm delighted to welcome Dr. Lisa Taylor-Swanson from the University of Utah. Dr. Taylor-Swanson is a women's health researcher and a licensed acupuncturist who's focused on improving midlife women's health through equitable evidence-based care. She did her undergraduate training at the University of Utah with a major in psychology and a minor in women's studies, graduated cum laude, and then went on to do a master's degree in acupuncture and oriental medicine at the Seattle Institute of Oriental Medicine. She then went on to do her PhD in nursing science at the School of Nursing at the University of Washington, and has gone on to be an NIH-funded investigator. Is currently an associate professor at the University of Utah with a primary appointment in the College of Nursing and an adjunct appointment in OBGYN. She developed through multiple NIH grants the MAcOM project, which we're going to hear all about this morning, which integrates evidence-based conventional and integrative healthcare approaches to address the menopausal transition. She's since adapted that project for both Indigenous and Hispanic populations through additional NIH grants, and is also MPI of a decentralized confirmatory trial of acupuncture for veterans with Gulf War illness, which is funded by the Department of Defense. Her work has earned her the 2023 Leadership in Inclusive Excellence Award and recognition for advancing diversity in healthcare. And she's currently also the co-president of the Society of Acupuncture Research. So I'm thrilled that she's come to devote time to talk to us today. She'll be giving this hour lecture. And then if you are able to stay for our second lecture, that will be a research seminar focused more on the NIH projects that we have talked about. Okay, so thank you. Welcome, Dr. Taylor-Swanson.
Thanks very much, Dr. Coggan-Carr. So first off, I'll say I am really having a great time here, and my sinuses are not. So I've got a tissue. I'm sorry, I have to blow my nose during this talk, but here we are. Where do I advance? There's usually a keyboard. It's Bethany. Thanks. Spacebar. Thank you. Appreciate it. Tech gets us sometimes. So thanks again for that kind welcome. And it seems like a very Vermont style, very warm and a welcoming approach to the morning. So I'm going to talk a bit about the evidence across, where did that go? About the evidence across, I guess we're just going to skip that slide, across women's health lifespan. Of course, women's health is OBGYN and so much more. So we're going to talk broadly today. But I first want to acknowledge that I have no conflicts to disclose and that where I work right now in Salt Lake City, Utah is the traditional and ancestral homeland of the Shoshone, Paiute, Goshute, and Ute tribes. And here in Burlington is the ancestral nation location of the Abenaki Nation and Wabanaki Confederacy. And I also want to start off by acknowledging the relationship between tribes, tribal nations, and the federal government. So, of course, women's health is a massive topic. And when I was preparing for today, I thought, well, what in the world am I going to talk about? I could talk for about 7 days. There's so much literature to cover. So like any good clinician scientist, I went to the research and the literature, and I first searched up, okay, women's health. Well, there's 3,000 hits for acupuncture research. Gyne, little, fewer, around 1,000. Obstetrics, just over 1,000, so on and so forth. And so again, I kept thinking, what do I really want to hit? What are some of the high points to cover today? So then I found a terrific paper to really help me focus my thinking. And this is the second paper this group has written, only covering from 2017 to 2022. So the top hits of acupuncture research across women's and men's health. So on the right, I'll draw your attention to that yellow rectangle. What I'm going to focus on, of course, is the top tier. We're looking at high quality or moderate to high quality evidence. Again, acupuncture across many, many topics. And what this review demonstrates is that there were 92 papers, again, across women's and men's health, demonstrating positive to potentially positive effect of acupuncture for pick a condition. And then on the right-hand side, you'll note in that rectangle in the middle, evidence previously that was positive, potentially positive, had moved to positive effect just in 5 years. So the change in literature really is pretty dramatic. There's a lot of good work being done by a lot of good people. So within the list of women relevant conditions, I decided on migraine because I suffer from them, and it's really common in clinic, of course, across girls' and women's lifespan. And menopause, that's my topic, so of course I picked that as well. But I also really wanted to pick something that's close to the bone for many of you and for many clinicians across training, and that is IUD insertion pain. And I'll get to a third part of my rationale for that as well when I get to that topic. So this is what we're going to cover today: migraine, IUD insertion pain, and menopause. I will say I've had the good fortune of treating both girls and women for migraine with acupuncture in my private practice. I was full-time in private practice for about 15 years before I returned to the research bug, and that's when I went back and did my PhD. So for me, reading the literature, it made a lot of sense. It really affirmed what I saw in clinic. Acupuncture is quite effective. But even more so, it affirmed what I saw in clinic, which was girls and women really suffer from migraines. They can be absolutely debilitating. Boys and men do as well, but as we all know, it's far more girls and women. What I thought was interesting is that we all know estrogen, that's a driver for migraines, so triggered in terms of our menses. But what was interesting, that little sub-bullet there, is that a change in progesterone has recently been demonstrated to be a trigger for adolescent girls with their migraines. So then again, let's dive into the literature on acupuncture itself and what we can see in terms of migraine prophylaxis. This is USVA. This is a evidence map from the Veterans Administration, 2014. And basically, they demonstrated if you see at the top left, those bubbles, high confidence, they really have a high confidence level of the literature on acupuncture for migraine. So that little arrow on the right-hand side shows you where migraine is on that very, very busy diagram. And there's 22 papers that they could summarize at that point in time, and really did demonstrate, again, a strong level of confidence way back almost a decade ago, more than a decade ago, from the VA. So moving forward from there, in 2016, there was a Cochrane review, which we all know, highly rigorous, reputable, where they were able to review 22 trials, almost 5,000 participants. There was acupuncture control. This morning, I'll talk a fair bit about sham acupuncture control and some of the challenges therein. 5 had prophylaxis drug treatment as well. Overall, the quality was moderate. We know that's a challenge in research across topics. We want high quality research, and sometimes we end up with moderate, and that's frustrating. But in this Cochrane review, they found that about half of the patients receiving acupuncture had their frequency of headache at least halved, compared to 41% with sham acupuncture and 46% with prophylactic drugs. So with the Cochrane Library review, they also noted that there were fewer adverse events. Unsurprisingly, acupuncture has a very minuscule adverse event rate compared to medications in this review. Moving forward in 2017, this was a single RCT published in JAMA, so this was pretty exciting to see. In this study, they had 249 patients with migraine without aura. The dose is massive. I don't think we could deliver this easily. 5 days a week for 4 weeks, so needling people every weekday or something like that therein. But happily, the results were quite vigorous, and acupuncture outperformed sham and waitlist, unsurprisingly, in terms of the waitlist. Moving forward, this is a systematic review from the Headache Association, American Headache Society, published in 2019. So I wanted to take us through the literature kind of year by year. And they reviewed, curiously, just 7 trials. There was more literature to review, but they chose 7, comparing acupuncture to pharmacologic treatment. So they did not include any of the acupuncture sham-controlled studies, and that's probably where they landed at the 7. And they did demonstrate that acupuncture was more effective than standard pharmacological care for migraine prevention, which is really quite stunning. But then they said, acupuncture is becoming more widely available, but its effectiveness is still in question, despite that there were few treatments having class A or B evidence. So it was kind of confusing because we have this pretty significant finding, and then there's kind of some backpedaling from there. And there was a very compelling discussion of this on the American Headache Society website. So then moving forward in 2021, this is a systematic review of clinical practice guidelines. So they're not reviewing RCTs, but rather guidelines from around the world on headache treatment by acupuncture. So there were 6 clinical practice guidelines that recommended acupuncture for various conditions. And again, just focusing in only on migraine. There were 2 clinical practice guidelines, one from Denmark and one from Qatar, that did recommend acupuncture for migraine prophylaxis. None of the folks reviewing migraine noted in red, which would be no way, don't use acupuncture, it's unsafe. None of them were yellow, which was unclear. The table that I cropped is large, and so those NAs, it just meant that those particular guidelines did not have nothing that was applicable regarding migraine. But further on the table, there were other things they reviewed. So just to make clear why you only see 2 green squares and a bunch of NAs. It was my cropping. And then I thought this was a very interesting, I just picked one single review of 2 acupoints. I thought it was interesting because it's actionable in clinic. It's very approachable to consider potentially a practice change, given the evidence I've just mentioned. So this is, again, a systematic review and meta-analysis of 19 RCTs. Some of the RCTs compared acupuncture to pharmacotherapy, others to sham. Over 1,000 participants. And again, it's just 2 points, easy to find, right on the hand. And it's actually the parallel on the foot between the first and second toe. And they're very, very commonly used in practice. Very easy to find, easy to needle. Sometimes a little painful if you're too aggressive on the needling technique, though. So with this study, they did find both for their primary outcome of headache intensity with a visual analog scale report, as well as several of their secondary outcomes were statistically significantly improved. So it was really quite compelling to see these 2 points really can do quite a bit of good for our patients. So let's take this back to clinical practice. I posed the idea, these might be 2 easy acupoints to add into clinical practice. Cochrane's bottom line statement, again, that was way back to 2006. They said the available evidence suggests that a course of treatment of at least 6 treatments really can be a valuable option for folks with migraine. So again, that was way back to the Cochrane review and all that evidence that we have since then. So I posit the question, it might be simple and easy to add these 2 acupoints in clinical practice. There's a whole other literature to discuss in terms of acupressure at home. If anyone has a question about that at the end, we actually have an interesting pilot study for interstitial lung diseases where folks are using either puncture in the clinic or pressure at home, and we're seeing results with both for anxiety-related dyspnea. So I would wonder if, given the evidence that we have, if there's an implementation problem, like really, do we have a barrier that's really about how do we get from all of our knowledge that's been generated to implementing this in the clinical setting? And I'll talk about this review article at the end of my talk. So I'm going to move on to pain with IUD insertion. And again, that was not on the list of, we've got lots of evidence on this in terms of acupuncture's efficacy. So why did I pick it? Well, I have a teenage daughter, for one. She's talking about an IUD, as are all her friends. What do we do? Are we going to do this or not? And it's in the media. So about 2023, this really started hitting, and I'm sure you all heard tons from your patients or your family members, where girls and women were talking a lot more about, wow, this is really an uncomfortable procedure for some. And it was, again, hitting the socials, all through the news. It was on and on. The CDC responded 2024, and ACOG responded in 2025 with a clinical consensus paper. So just to go back a bit, well, how big of a problem is this? About 50 to 80% of women do experience moderate, girls and women, moderate to severe pain with IUD insertion. So it's the majority, you could say. In one study, 42% of women said it was an unacceptable level of pain. Yet at the very bottom of the slide, 83% of respondents in a different study said, yeah, it might have been awful, but it was worth it. So then what do we do? If it hurts, but it's worth it, women and girls are going to undergo this procedure because they need to. There's really a question of, is there something simple? Is there something acceptable that we can do for our patients to decrease their pain with IUD insertion? So going back to that ACOG clinical consensus, they noted really, yes, we do need to check in. I'm sure you've all read this. But clinicians really need to have a better understanding of pain management options, and noting that there can be systemic racism and bias about how pain is experienced and who pays attention, who clinically pays attention to that pain being described by our patients. In red, I've noted with extra emphasis, if there's a history of abuse, sexual assault, chronic pelvic pain, there's very high likelihood that girls and women are going to have a difficult time with their IUD insertion, and we need to pay extra attention and care there. The ACOG consensus statement also noted, we have not enough evidence on non-pharma pain management. And I was happy to see, as I was doing my research, I found, here's one little RCT I can talk about, and ACOG found it too. So they noted here the small RCT. They did assess pain, and I'll show you in the next couple slides, after the insertion, but they didn't assess pain when it was being inserted. So they said, this is a real limitation, which is for sure the case. Oh, I want to go back. They also noted at the bottom of that slide, anxiety. Of course, if I have a history of other pain conditions, I might be anxious knowing I'm going to go in for an IUD insertion procedure. So that anxiety was something the ACOG noted really needed to be addressed in this population. So here's that small study that ACOG noted in their consensus, in their clinical statement. 72 women, they looked at acupuncture or nothing. And they excluded, as you see here, folks who couldn't properly consent or had other concerns, a reason not to provide acupuncture therapy. And this is a visual analog scale. On the left, you see quite a dramatic difference between acupuncture and no acupuncture pain ratings at 3 minutes, is statistically significantly different. And then on the right at 10 minutes, there's actually even further analgesia. The kind of pain is wearing off, you could say. Again, statistically significant differences, though, between those two groups. Looking a little closer at this data, it's pretty stunning on the right. The Cohen's D is 1.03 at 3 minutes and 1.13. And we usually see Cohen's D like small effect size, 0.2 to 3, 1 to 3, moderate, 4 to 6, and this is over 1. So this is really a pretty strong effect size difference. In addition to the ACOG concerns, I thought, well, why did they not check with either cold pressor test or something before the IUD insertion so they could have a sense of girls and women who were quite strong in their pain response and reporting that, or less so, they could have some subgroup different analyses. That was another concern I had. And again, as ACOG noted, why didn't they measure pain with insertion as well as 3 minutes, 10 minutes? And then I thought, why did they not even compare it to lidocaine? Like that would be a pretty straight up comparison. And so for anyone who didn't want lidocaine or couldn't receive that if they had an allergy or something, then we'd have a head-to-head comparison. I don't know why they didn't do that, but I think it could be done. And then I found an interesting review of clinical evidence about IUD insertion published in the OBGYN survey journal. And they noted to be similar that, really folks at risk for severe pain, a history of violence or dysmenorrhea, really we need to look at how we can help control that pain with IUD insertion. And they did note, what about having more research on acupuncture and other medications as noted at the bottom of that slide. So coming back to clinic, is this relevant? Again, I don't have a mountain of evidence to stand on, but there's something to stand on. And it always starts with our patients, right? We need to we always do, but do the very best we can by them. And given there's a signal that we can follow of pain reduction with acupuncture before IUD insertion, my thought is, why not? Why not conduct more work on this? And it could even be a simple quality improvement project. Large intestine 4 is indicated on the hand for anxiety, as well as helping with IUD insertion pain. So it's 2 for 1, and that responds to ACOG's concern about anxiety being addressed with respect to IUD insertion. And again, why not trial it against lidocaine? Let's see head to head how strongly or not this performs. Acupuncture is really inexpensive. It's relaxing. Actually, raise your hand if you had acupuncture, if you care to disclose. So a lot of people, you know the AcuNap. It's amazing, right? It's one of my favorite things. Having some relaxation. I don't know if we could have that for patients right before an IUD insertion. It might not be the most relaxing moment, but it typically is relaxing, and also with very, very few adverse events. So, I would conclude that here with the topic of IUD insertion pain, we have an opportunity both for research and potentially for practice change, just to have, again, a quality improvement practice initiative and see what we see in the clinic. So many of you know menopause is having a moment. It's in the media, it's in the socials, it's everywhere. I'm proud to say I was studying menopause a decade before that, so I haven't been riding the wave, but I am riding the wave currently because it's such a relief. I will note that when I started my research career, I should have listened to what everybody said. My ADR, my associate dean for research, literally said, "Lisa, nobody dies from menopause. Why are you studying this?" And I said, because it matters. Women are really not just suffering. My next talk, actually, I'll talk more about some of the associations between moderate to severe vasomotor symptoms and very, very serious health outcomes. So it really does matter. But again, back to the socials, it's having a moment. And it really started big in 2023 with this article in the New York Times. And it just seemed like every few months after that, there were more articles coming out. Oprah is talking about it. Drew Barrymore is talking about it. I'm sure you've been hearing all about this. There's an interesting article I found from Medscape as clinicians, like, how do I deal with all this social chatter? My patients are coming in and saying, I should take this, I should take that. And I myself studied, what are women talking about? I followed #menopause on Instagram to try to see what they were posting with respect to their menopause experiences. And it's a big deal. It's a big fiscal deal. In last year, women spent 18 billion with a B on, you name it, creams and this and that and the other, and some evidence-based interventions, thankfully, too. And that's projected to increase to 27 billion by 2030. So there's every reason to be sure that we can provide evidence-based care for our patients, because if they can't get it from us, they are getting something from somebody else, and it's probably not evidence-based. So you might be wondering, well, where does integrative health stand on this topic? Why should we be thinking about this? Because women are using it. A quarter to half of women in one survey were using complementary integrative approaches, including acupuncture. And a majority of them believe they're effective. So if we have literature to support that, then we know that that's the case. But if it's just belief, that's not very good. Excuse me while I take a drink of water. And one thing we can say also, I'm sure everyone here knows this, is that it's often very difficult to access integrative therapeutics. I was in private practice myself in Washington State. It was mainly an insurance practice there. Acupuncture is a mandated, all of integrative health from 1990 is mandated to be covered by health insurance in Washington State. So it was a very different picture than most of the rest of the country. So outside that insurance bubble of wonderfulness, because people could get what they needed and wanted, it becomes kind of a bourgeois medicine. Like, if I can pay out of pocket, then I can go get acupuncture or massage or what have you. So it is not widely available in most cases, which is quite unfortunate. I will be speaking more about the interventions that I've co-developed with women in my next talk, but I will say my own experience really does mirror the literature. So in MenoGap, which is menopause intervention designed to fill the chasm, the gap of care for menopausal women, one participant said, acupuncture was the best part. I'm not going to stop. I'll just go get acupuncture in private practices, because they enjoyed receiving it in our group medical visit. Working with Indigenous women, they said, yeah, we actually want natural medicine first, like acupuncture, but we don't know where to get it. And also working with Hispanic and Latino women, they said the same thing. We really want to receive acupuncture, but we just really can't. We don't know where to find it. So So I had the good fortune of phenomenal mentorship as a grad student at UW, and this table on the left was one of 5 systematic reviews we conducted with my chair. I led the one on acupuncture and East Asian medicine, and this column that I've just highlighted is the evidence that we had as of 2015 regarding acupuncture for hot flashes and night sweats. So it was a preponderance of the RCTs did demonstrate a positive effect that you see indicated by the plus signs. We also see, quite interestingly, BORUD, this is the AcuFlash study that was conducted in Norway, positive effects on that top line there, both for hot flashes, sleep, and pain. But those effects disappeared or washed out at 6 and 12 months. They did not persist. The table on the right is in review. It's our team updating the literature since that first paper a decade ago. And wow, we see a lot of evidence, all these various RCTs demonstrating efficacy of acupuncture for hot flashes and night sweats, the vasomotor experience. And very interesting, this is a study conducted by Nancy Avis at Wake Forest here in the States in 2016. I just highlighted their persistence of effects over 6 months across all the symptoms in the symptom cluster. Briefly, there's this identified symptom cluster. So menopausal transition is so much more than vasomotor symptoms. Pain, sleep, mood, cognition tend to cluster together. And you can imagine very easily, if I'm having a vasomotor event at night, I'm not sleeping well. When I'm not sleeping well, I have mood dysregulation in the day when it's happening, where weeks, days, months, years. How am I going to think straight if I'm not sleeping well? And if things are kind of wonky, pain easily gets thrown into that mix as well. So again, that's an update from my lab just as currently. So this is an umbrella systematic review and meta-analysis. Really interesting work. So if the umbrella part is new terminology, what that means is they took prior systematic reviews and meta-analyses, and they took the meta-analyses and added more recent RCTs onto it. So it's, everything available, basically, put it together to see what they would get. And this bar highlights that acupuncture for vasomotor symptoms, this top one is hot flash frequency. Those bars are left of 0, favoring acupuncture. And the bottom one is hot flash severity. So how frequent, how often are these happening, and how severe? And then the effect sizes are moderate, 0.66 for frequency, 0.49 for severity. So again, acupuncture compared to no acupuncture, we have a moderate effect size. It is robust. But then when we compare acupuncture to sham, the long and the short of it is sham is not inert. It's a very active and effective control in this sense clinically. We only see 0.21 and 0.35 effect sizes. So that very large effect when we compare acupuncture to no acupuncture is quite reduced comparing acupuncture to sham. So again, I'll talk some more later in this talk this morning, but sham is not inert. It's fascinating, actually, and a little disturbing because what do? We don't have a proper control in that sense for clinical trial work. Looking across the systems from neurologic systems to endocrine systems, there's effects. Sham acupuncture, sometimes it's just contact needling, sometimes it's supposedly like off location, but it's still, again, physiologically inactive wherever we needle on the body. And that's actually the fact now that NIH's division that funds complementary and integrative medicine, NCCIH, they won't fund sham-controlled acupuncture trials anymore. And to be clear, clinical trials, they won't fund any sham work there, but basic science, that's an option for sure. So I wanted to talk just a little bit about menopause is, again, so much more than hot flashes. It's this whole person phenomenon. And if you think back to puberty, of course, it was not just like, oh, all of a sudden I have some pubic hair. There's only one thing changed. Your whole person has changed. Your voice changed. And it's very much this whole person phenomenon at midlife. So this was a pretty interesting clustering of 145,000 symptom logs. And on the right, that's a kind of nice pictorial. I mean, you can literally see the different phenotypes of premenopause, perimenopause, and postmenopause. And the symptoms that vary, I've highlighted in red at the top. And of course, premenopause, when women are cycling right as rain, if they're regular, there's really menstrual cycle associated symptoms. Perry, when all heck breaks loose, and I'll talk about this a bit later this morning as well, we definitely see hot flashes and night sweats. The vasomotor events are really starting to crank up, and that can persist into menopause. 10 to 13% of women in their 60s and 70s are still having vasomotor events. So it's not just early postmenopause, it can even persist into later menopause. Later postmenopause. So again, just looking at the symptom cluster topic, these are the slides. This is the slide I showed you before, that is more than hot flashes that are concurrently treated. So acupuncture is a whole person intervention, can address many symptoms concurrently. And we see this absolutely in the more recent work that we've done, looking at hot flashes, sleep, and mood. There's really a good amount of evidence saying, yeah, actually acupuncture seems to help women with their vasomotor events, with their sleep, with their mood. The same women measured in the same study with the same intervention. It's a concurrent effect. More bang for your buck, something like that. And a paper that I wrote, yeah, actually, I think of this as a whole person phenomenon and really looking at how acupuncture can support these various concerns through the menopausal transition and beyond. And then just to highlight a couple more papers, and then I'll get to some of the additional controversy. Is that I looked at some meta-analyses for these other symptoms that I mentioned in that symptom cluster. So looking at insomnia when women aren't able to sleep well compared to control, acupuncture definitely significantly improves sleep, and that was published in Maturitas. And then menopausal depressive disorder, acupuncture outperformed comparatives of medication, placebo, and sham in their various studies. Again, this is a meta-analysis across papers. Really showing a strong effect size there as well. So do we use acupuncture or not? I mean, when we look to the Menopause Society, which used to be NAMS that you see here, the North American Menopause Society, they don't recommend acupuncture. They do recommend, in terms of integrative therapeutics, cognitive behavioral therapy, sorry, I didn't define that acronym there, and clinical hypnosis. Now, what's interesting is the preponderance of evidence on these two interventions are when they compare CBT and hypnosis to usual care. And taking your memory back to that slide that was pretty busy, but acupuncture compared to no acupuncture or usual care, we see those moderate effect sizes. But because we have this messy situation of sham acupuncture, when the Menopause Society looked at that literature, they said, well, acupuncture doesn't outperform sham, so we don't recommend it. Whereas if we look head to head with usual care, CBT, clinical hypnosis, and acupuncture, we really do see those strong effect sizes. But I want to be clear, at present, the Menopause Society does not recommend acupuncture. And it is, again, this sham issue, and it's the issue of sham just not being inert. It's, you know, if you compare in a drug study, whatever medication to half a dose of the medication, well, it's harder to show a big effect size. It's not an actual placebo being used. This was quite interesting too, much more recent, just a couple months ago, paper. It was just a clinical insight, kind of a summary, 3 pages published by leaders in the field in JAMA. They didn't even mention acupuncture when they were looking at non-hormonal interventions. So it is not on the map, and I'm pretty gutted to say, but it's the state of the science right now. So to dive a little bit more deeply into the topic of sham acupuncture, I mentioned that it's not inert. It produces larger physiologic and analgesic effects than, you know, in inactive placebo. That's been compared. Brain imaging shows all kinds of neurobiological activity. Location is everything. And here's something to think about. So that study that I mentioned using the hand point and the foot point for migraine, there's this fascinating deep dive into, well, because if you think about it, like, why in the world would you needle the hand and the foot to help the head? Well, this is why. Because into the weeds there, I've made it bold so it's a little easier to track. But basically, there's this really strong density of sympathetic fibers. Sorry, our Li4 is the one on the hand, or you can see from the description, liver 3 is on the foot. So there's this density of sympathetic fibers, really essential for vasomotor regulation, and that's key in terms of dilation and constriction and migraines. And then that last bullet point, there's actually histamine responses that are triggered, and really significant and not statistically significant, meaningfully relevant mediators of migraine pain and again, vasodilation. And so, just taking a step back from the literature, I have to say as a scientist and as a clinician, I think, how in the world did they figure that out? All those 2,000 years ago, use this point on your hand and this point on your foot and your head gets better. But they noticed it and wrote it down. And then over the millennia, we have now modern science to really shed some light on what's been used, clinically for so long. It's really quite interesting. And then I'd had to, of course, give a shout out to alum faculty member Helen Langevin. And she headed up this paper over, almost a decade, 20 years ago. Got to get my math right. I'm still kind of tired. 20 years ago, that we really have a problem with sham. Like this is really not an effective control, but we've just still had to do that scientifically because reviewers are requiring it, even though it is not proper science. It's just not a sensible way to design a trial when you need to see what's the effect of something compared to not receiving that something. So I would suggest we just have a study design issue and we need to sort things out. And I also wonder if we have really broad sweeping implementation issues as well. For sure, of course, like you saw with migraine, strong evidence. Why doesn't everybody get told, what about acupuncture in this clinical setting, or go seek it for yourself? So in terms of barriers to implementation, this paper was recently published and did a beautiful, thorough job of mapping out barriers to implementation of acupuncture. They range from the individual, both patients and providers. Like, I don't know about acupuncture. What's the evidence? I don't have time to read all this literature, perhaps. And it might not be acceptable. Some people are very, of course, needle phobic, I myself included. But knowing that acupuncture needles, for all of you who have experienced it, they're teeny. They're very either pain-free or minimal sensation, not like having a blood draw all over your body. That would be horrific. But not having previous experience. And likewise, as a clinician, how could I feel comfortable describing acupuncture to my patient if I, don't have any previous experience with it myself? Social determinants of health can be a barrier as well. So there's all these individual level barriers. And then interpersonal barriers, like there's not so many acupuncturists that are PhD prepared. So folks in my profession, we're trained with, of course, basic biomedical knowledge, but not everybody talks shop. And so really being able to talk shop with each other is essential, and having these communication barriers reduced between acupuncturists, physicians, nurse practitioners, PAs, so on and so forth. And also, it's really critical to explain coherently and clearly, well, how does this medicine work? Because again, the patient might think, well, why do you needle my hand and my foot when my head is the problem? So we just need to really be able to explain that to our patients. Of course, there's organizational barriers. We're not having leadership support in health sciences sometimes. Credentialing barriers. I faced that in Utah. It was an entire year to get me credentialed. Patients are suffering. Like, why are we waiting this long? Lack of facility space, on and on. I won't go through the minutiae, but there's plenty of barriers to overcome. But what I'd like to end on this morning is that, there's a lot we can do. There are ways forward to address all these barriers. Oh, I forgot, there's facilitators first. I'll talk about facilitators first. There's a lot we can do on the individual level to really educate one another in terms of collegially, as well as our patients, and really having well-documented evidence. We really need that high level of rigor to be able to demonstrate strongly and clearly that, yeah, that works, or no, it doesn't, but not having, poorly or moderately designed studies. It's just not helpful. And then there's some simple things we can do in terms of both the individual and interpersonal levels, building these communication channels, referral networks in our practices. One thing that I've done is travel to UC Irvine last year with colleagues in nursing, and we provided an interprofessional or IPE experience for the DNP students. And so what was really fun about it, and actually quite successful, is we talked about, with all the evidence like I'm presenting today, what's the evidence on acupuncture in terms of efficacy? What's the evidence regarding safety? And then these barriers. Well, what about insurance coverage? In California, actually, it's pretty much like Washington. There's not a lot of barriers there. And so we took the time to educate nursing practitioner students about the intervention, what's the science, how to talk to their patients about it. So really addressing a lot of these barriers. And then we needled whoever wanted to be needled. And so we had a group acupuncture experience. And so that checked the box in terms of, oh yeah, I've experienced acupuncture if they wanted to receive it. Small needles, it didn't hurt, I felt relaxed. And several students reported to my colleagues later who are there every week faculty that even that one single treatment, they noticed a positive effect for them and their stress levels and getting ready for finals and whatnot. And then we also talked about Tai Chi. And a colleague there is a wizard Tai Chi scientist and presented his work and colleagues in terms of the science of Tai Chi. And then we did Tai Chi together, which was a really nice way, again, for the DNP students to experience this. So I think there's a lot of opportunity to have simple, it's just a 2-hour, hour and a half class where we talk shop, what's the evidence, what's the safety, how do I refer? And then they got to experience the interventions. And I think that's one way to really take down some of these barriers. Of course, talking to our patients, explaining how this works, both conventionally and if they're interested in East Asian medicine theory, we can always describe that as well. And just addressing practical issues, like having clinics in areas where it's close to home or close to work. And actually, I'll address that in my next talk. That's one of the things we've done with our Goal for Illness study is participants go to clinicians in their neighborhood or close to work and not all the way over to the VA. And of course, organizational, like without leadership support, we can't get anything done. So really having those champions is really essential to implementing acupuncture in more settings. And really having training and opportunities for fellows and folks who are interested, having group acupuncture. Right now, it's not at federally qualified health centers, and that'd be an easy implementation opportunity. And there's actually some research to back up that idea. And really addressing cost and lack of insurance reimbursement is a massive, probably, I would say, the number 1 or number 2 problem. So now I'm going to get to the part I'm very excited about and honored to describe briefly, which is that well-documented evidence piece. Again, without data, we're really lost. So some international colleagues, including a colleague that both David and I work with, have set out to develop a core outcome set, or COS. And it's with this COMET initiative. It's an international initiative across topics. There's actually already 2, COMET statements in the menopause space. They're called COMA. And the core outcome sets are, if you think about this, when you're seeing your patient and you're in your EHR, Epic, or whatever you use, and if everybody just documents the same handful of things, say if we're talking about menopausal symptoms, we're focusing in on vasomotor, how frequent are they, how severe, how bothersome, because some women have them all day long, but they somehow cope with it and don't describe it as bothersome. So you really need those little differences in symptom experience. And if everyone's collecting that same data and we can download it without identifiers and all of that, just think of the phenomenal data set we would have to really demonstrate what's happening in practice. And that's what we're doing with the ASTRO initiative, which is an acronym standing for Acupuncture Sets of Trial Reported Core Outcomes. So we want these to be used in trials. We want these to be used in clinical settings. So of course, trials will give us that efficacy data, and the clinical practice will give us the effectiveness data. So we're wanting to really have that consistency. And of course, we need to have, feasibility outcomes as well as patient-reported outcomes. So is this an acceptable intervention? Are they satisfied with their care? And cost, as we all know, if it's expensive, it's not going to work. So really, what is the cost of delivering this? And if there's any cost savings, of course. And then, of course, secondary outcomes, if they're tracking the pulse, tongue, diagnostics that are used, other symptoms as well. So we have this in review at BMJ, and it's posted on medRxiv if anyone's interested. But we went through a lot of work. It was actually 3 years of work. And we started, like everyone does, in the literature. So and we looked at women's health across the lifespan, hence the title of my talk as well today. So we looked at menstrual health, PCOS, fertility, pregnancy, and menopause. The papers ranged from like 18 on my topic to 185 for pregnancy. And there were hundreds of outcomes that were measured. It was really quite staggering. So we literally documented all those hundreds of outcomes to sort out, well, which ones are relevant? And then we had a series of consensus building conversations at conferences and online by survey to look at all those outcomes, and people rated them. And then we whittled it down with high ratings, whittled it down and then down again. And finally came on the right to the safety outcomes that we would like everyone to report. And then East Asian medicine specific outcomes. For example, demographics, how they respond to treatment in terms of their mood, their sleep, their pain, East Asian medicine diagnostics. And again, the feasibility, acceptability that I mentioned, that's on the bottom right. Excuse me. So this is a way to try to organize both researchers and clinicians. We want to mobilize the profession to collect good data. So in close, I'll say that I hope that I've given you some useful information and actionable evidence regarding acupuncture's effectiveness for migraine, the potential role of acupuncture for IUD insertion pain, because as I noted, there's just burgeoning beginning level of evidence there, and then menopause as well. And it always takes a village. I'm so lucky to have phenomenal collaborators at the University of Utah, that's the UU, in nursing, OBGYN, the Urban Indian Center of Salt Lake, collaborators around the country, dear friends and colleagues with whom I enjoy working, international colleagues on both the ASTRO project and others, and then, excuse me, mentees. Of course, none of us can have a vigorous lab without phenomenal students and colleagues with whom to work. So with that, I'll say thank you, and I've left lots of time for questions. Well, 10 minutes.
We have one question on Zoom.
Oh, great.
So Shauna's asked, can you please tell us how you explain in layman's terms to your patients the way acupuncture works?
Oh, that's a great question, which was, how do I explain to my patient in laywoman's terms, how acupuncture works? So I always ask them first, do you want the conventional, or they don't know that word. So I'll say, do you want the medical information or do you want the East Asian medicine? And usually they'll say, yeah, I think I want the medical information. I'll say, great. So what I'll talk about is first a metaphor, because very often there's not a lot of jargon that's useful for patients. I don't want to snowball them with unuseful jargon. But for example, if I'm treating a patient with migraine or I'm treating a patient with dysmenorrhea, I'll say, so today I'm going to use acupuncture, where you might think I would use the needles. I might use some head points, but I'm going to use points that are not on your head if you're having a migraine, or not on your abdomen if you're having a painful period. And the reason is that there's scientific evidence connecting, point A to point B. And I'll even say, well, remember when you were in kindergarten, you saying the head bone's connected to the shoulder bone and all of that? Well, your whole body's interconnected. And that's the truth of it in terms of conventional modern science and in terms of acupuncture. Now, sometimes patients will say, yeah, give me the East Asian medicine, give me the jargon. Like, what's that all about? And sometimes, say in the case of vasomotor, hot flashes and night sweats with vasomotor experiences, I've had patients say, Lisa, I wake up and then I have a hot flash. Why is that? And other patients will say, I wake up and I've already had a hot flash or a night sweat because they're asleep. Why is it? So the opposite direction happens for different patients. And I can explain that in East Asian medicine concepts. I have no scientific data to explain why some women flash first and then wake up, and some wake up and they've already had the flash. So I'll use either vernacular depending upon what they want, but I think, again, making it explainable, whether it's the conventional information that they want or the East Asian medicine. And I'll note too, when I'm able to explain it, even in weird terms, I don't use all the weird terms, but just like, yeah, it's this meridian that's bothered because you wake up first and it opens the eyes or what have you. Women have said to me, Lisa, that's amazing. You can explain why I have a flash first and then I wake up, or the other way, because nobody could explain that to me. So even though it's unfamiliar jargon, patients find that helpful because they have been seen and understood. And that really goes a long way. I think the other metaphor I use, if they want more of the kind of why do you needle here and the pain's there or the problems elsewhere, is I'll talk about, we have these meridians on the body, and this is where I use some of the East Asian medicine jargon, but it's really understandable. And so I'll say, the meridians in your body are like, a ditch and a canal that we have for irrigating the farm. And so if there's open, nice flowing water, that's like in the body, everything's flowing well. Your intracellular fluid, the extracellular, your chi, blood, whatever you want to talk about, is moving like it should. But if there's a block in that irrigation ditch, there's weeds or whatever growing there, and there's a block in the body, then you're going to have pain there. So we work upstream and work downstream. So we're going to like dig that ditch out, but you got to move the whole irrigation ditch. And so I find usually a little quicker way to say that to patients, but that's helpful because it's concrete and they can understand it. And I also note if there's a blockade in that ditch, the water upstream is turbid. And we know about that in the body where there's toxins and all kinds of inflammation. That's the new fashioned way of saying the old fashioned stuff. And patients often find that helpful. So that's what I would say. Any other questions?
Hi, thank you for a great talk.
Yeah.
I'm curious about the persistence of effect in acupuncture and whether that's part of like a barrier. So if you think about pharmacologics, you take it and while you're taking it, it has an effect. When you stop it, usually that effect goes away.
Yeah.
And one of the requirements for acupuncture is actually to have constant contact with a professional who's doing it if it doesn't have a persistence. It creates that's a unique challenge relative to an ongoing therapy. And I'm wondering, what do we know about its persistence? Do you have to keep it going to have the effect? Does it have a residual?
Yeah, thank you for that question about persistence of effect with acupuncture therapy. So I have two responses. One is clinical observation and the other is the literature. And clinically, I always, first treatment, would tell patients, my job is to work myself out of a job. And so what we're going to do is time the treatments for persistence of effect, really. And so initially, depending upon how severe their dysmenorrhea or their whatever I was treating them for was, if it was very severe, meaning like I had a patient who couldn't play on the ground with their grandkids, they were so stiff and miserable, or, dysmenorrhea was so horrific, this teenager couldn't go to school, then it was twice a week. Well, not in the case of dysmenorrhea. So we'll just say pain that's so horrific, it's limiting their activities of daily life. Twice a week acupuncture until like they notice, oh yeah, I'm feeling better. Then I would spread it out to once a week. Oh yeah, I have persistence of effect. I'm still feeling as good or better. And then I'd spread it out even further still until I'd say, let's take a break. It's been a couple months or however long, and then come back if it starts to recur. So clinically, we're always working ourselves out of a job is the goal, to really see them feeling better and then they're out the door and on their way. Research-wise, I noted in terms of menopause, we do see persistence of effect. There's a few other studies that demonstrate it as well. And that's 6 months out without treatment, without that intervention. I mean, there may have been some people who got acupuncture on their own, but they tend to track that in the studies. And so that I think is really promising. 6 months later, no further treatment, that's holding steady. The last thing I'll note is in the Gulf War illness study we're conducting now is a confirmatory RCT. In the parent study, we did also see persistence of effect. It was a whopper of a dose. It was acupuncture twice a week, every week for 6 months. But then a follow-up 2 years later, we saw persistence of effect. The little bit tricky thing there is most people felt so good, they kept getting acupuncture. So that doesn't totally answer your question, but I hope the other two parts did. Yes, ma'am.
With all treatments, there are responders. Sorry. With all treatments, there are responders and non-responders. Right?
Yeah.
So how do you tell up front who's going to be a responder or non-responder? How do you try to get at that?
Oh, that's a good question. How do we sort out the non-responders and non-responders? Well, again, clinically in research. So in clinic, I never know. I really don't. I had a patient who would put his head in a block of ice. His migraines were so bad. And I was looking at him like, how am I going to do anything strong enough to help him when his pain is that severe? And I shocked myself. He got better. Another patient, he had bone mets. The pain was so severe. He was elderly. And again, I'm not oncology, but I was like, well, he doesn't know who else to see. He came back 3 weeks later and he was dancing with his wife. I could cry again, actually. He was dancing with his wife and he hadn't been able to dance for 6 months. I never would have guessed he'd be a responder. So that's clinically. And then other people, what have you. There's so many people that didn't get better. They didn't come back to see me. So I don't know. That's the other challenge. In research, I can't think of a way to identify responders and non-responders up front. but it's certainly a hot topic in research because we need to know. And one way that's been addressed, it's used across different intervention studies. There's SMART and MOST design, and it's basically staggering. So you randomize and have a few months of whatever the interventions are, and then non-responders that you identify with whatever scale score that it does or doesn't change, then re-randomize to other interventions. So that kind of design is being used, again, across different interventions solely, certainly not only acupuncture research. But we really don't have the evidence biomarker wise right now to so, like if you have high interleukin 6 or, TNF alpha, are you going to respond? We don't have that. We show those change, but I think that's, definitely with more scientific inquiry, something we hopefully could use at baseline, because then we could say to patients, oh yeah, I saw your labs, this was whatever, go get acupuncture or don't go get acupuncture. Hopefully we get there. That's a great question. Yes.
Thanks for a fascinating talk. Can you tell us a little bit about the training? Because one of the limitations of acupuncture is lack of trained providers.
Yeah, absolutely. Thanks for that question. So training, so I trained in 2001, I'm going to date myself. It was a master's prepared profession back then. And much like nursing, it's prepared to a doctorally prepared profession. So most folks nowadays do have a clinical doctorate. Regardless, it's about 2,500 to 3,000 hours between didactics and clinicals. It's a mountain of training. I will humbly say my school taught in Chinese as well. So I learned in English, but we were translating. So it was pretty epic, and I never got to go to a movie. So the other part that's key to know about the training is there's a deep bench, not as deep as y'all, of course, but a deep bench. So we have to be able to understand labs, to understand medications, to be able to talk shop with our colleagues. So there is a deep bench of training in terms of conventional medicine. And then, of course, the 2,000 years of literature to sort out in acupuncture theory. Did that help address your question in terms of the training, the hours, and it's conventional and
Physicians interested in training.
Oh, yeah.
Executive course?
Yes, yeah, there's the executive course. It's like 300-400 hours. There's a couple options. Definitely your colleague David could fill in better about that. But of course, you've got all the training, in terms of not inducing pneumothorax and all of that with needling. So then it's a matter of, what about the top hits? What are the top well-known points for condition, blah, 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 blah. And then if you take a little more time, well, again, why do we use the hand and the foot points? Why are they called the four gates? What is this theory all about? And so there's an option between top hits. This is what I can use quickly and effectively in clinic. And if you're fascinated with the 2,000 years of data and like literally you can read books in Chinese from 2,000 years ago that are relevant to diagnosing patients today. It's as mind-bending as it gets. And I said it in a very glowing way, but it's for sure legit. Like I literally diagnose my patients with patterns that have information about herbal formulas and acupoints that were written thousands of years ago. And that might be a good closing point, because the thing is, I tend to think in modern life, like we're so different, we're so stressed out, we're so busy. But some of those books talk about diabetes 2,000 years ago. It's different words, different treatments, but maybe as a species, we haven't changed all that much. And that'll be my closing thought. Thank you. So hopefully folks can stick around for the Act 2 of the Lisa Show. And if not, please feel free to go about your day and have a good one.